Hi, my name is Michelle Benzavango, and I will be presenting today on cellulitis. So, the chief complaint for my patient is as follows. This is an 89-year-old female who presents stating, "My leg is swollen and red and has been hurting." She states she noticed increased right lower extremity edema for the past week and erythema to her right shin began 4 days ago. This patient was recently hospitalized for cellulitis of the right great toe and RSV. So she was discharged home on January 25th on PO antibiotics, which she has now completed. She's presenting today with increased right lower extremity edema and area of erythema to the right shin that is warm to touch. She states she noted increased right lower extremity edema for the past week and erythema slash pain to the right shin began 4 days ago and has worsened gradually. There is no open area noted on the right shin. She reports 4 out of 10 pain to the right shin with palpation. She reports the pain is 2 out of 10 while ambulating, which is relieved when she sits with her leg elevated. The patient denies recent trauma to the right leg or any recent falls. She denies any insect bites or having spent any time outside recently. She denies being in any bodies of water recently, and she also denies shortness of breath, chest pain, fever, chills, nausea, and vomiting. So, for her review of systems, for her general slash constitutional system, the patient reports feeling in okay health. She reports exercise intolerance, but is able to ambulate with a walker. She denies fatigue, weight changes, fever, chills, night sweats, or malaise. For her HENT, she denies a headache. For her cardiovascular system, she denies chest pain, palpitations, but she does report increased swelling to the right lower extremity. For her pulmonary system, she denies cough, shortness of breath, and wheezing. For her integumentary system, she reports erythema and warmth to the right shin. And for her musculoskeletal system, she reports difficulty ambulating, and she reports joint pain and arthralgias, and she reports pain to the right shin. For her past medical history, she has a history of hypertension, hyperlipidemia, CAD, vertigo, and obesity. She has no pertinent surgical history. She has an allergy to codeine, which she says it made her confused in the past. She has no environmental allergies that she knows of, and her only food allergy is milk, and she gets diarrhea from it. The medications she's on are amlodipine, atorvastatin, clopidogrel, furosemide, metoprolol, sodium bicarb, meclizine, and vitamin B12. So for her social slash work history, she is a retired office manager. Her husband died 3 years ago. She denies smoking or use of any other tobacco products. She denies illicit drug use. She denies alcohol use. She lives in an apartment alone, but she does have a home health aide a few hours each day to assist with ADLs. She also has her daughter come and help her with ADLs, and her daughter does her shopping for her. She sees a physical therapist who comes to her home twice a week. She lives in a clean and safe environment, she reports, and she is able to ambulate around her apartment with a walker, although it is a little difficult for her due to her body habitus and weakness. For her family history, her mother died at age 90 with a past medical history of hypertension and hyperlipidemia. Her father died at age 83, and he had no known past medical history. Her brother is alive, age 84, and he has a past medical history of COPD, hypertension, and diabetes type 2. And her daughter is alive, age 60, with a past medical history of PCOS and hypertension. For her physical exam, her blood pressure was 152 over 84. Her heart rate was 62. Her respirations were 18. Her O2 sat was 95. Her weight is 209 pounds. She's 5'2", and her temperature is 97.6 degrees. For her constitutional exam, she is pleasant. She's well developed. She appears her stated age. She's oriented times three, and she maintained eye contact during the exam. She was in no acute distress during the exam. For her cardiovascular exam, I heard S1 and S2 heart sounds when I auscultated, and there were no extra heart sounds. For her pulmonary exam, she was dyspneic with exertion when he was trying to ambulate. But other than that, her respirations were easy and even. There was no dullness, no flatness, or no hyperresonance on auscultation, on percussion. On auscultation, there was no wheezing, rails, crackles, or ronchi. She had good air movement, normal breath sounds. For her upper extremities, she had bilateral, appropriate, even tone. There was no cyanosis. There was no edema to the upper extremities. I could feel her radial pulses. They're plus twos. and she had the expected sensation bilaterally in her upper extremities. And then for her lower extremities, she had abnormal motor strength in both the lower extremities with poor tone and limited range of motion. But that's chronic for her. That's not a new finding based on her review of systems. So her left lower extremity had trace pitting edema um, to her ankle. It had appropriate color and tone. Her pedal pulse was a +2 and palpable, and there were no open areas. Her right lower extremity, I found +1 pitting edema below the knee. She had a 9 by 4 centimeter oval red area to her shin. The area was warm to touch. There was no color change to the foot below that area. No cyanosis noted. The pedal pulse was +2 on that side. I could palpate it easily. There was no open areas to the shin, and the patient was reporting 4 out of 10 pain when I palpated that area, and there was no crepitus palpated. So, my working diagnosis for this patient is cellulitis of the right lower limb. This patient presented with clinical symptoms of cellulitis, including skin erythema, edema, and warmth. This patient is free of systemic infection symptoms such as fever, malaise, lethargy. And the diagnosis of cellulitis can be made based on clinical manifestation without further diagnostic testing. So, based on her symptoms and everything, this is her working diagnosis. For my differential diagnosis that I had to keep in mind, the first one was necrotizing fasciitis, which is an infection that goes deeper than cellulitis that results in destruction of the muscle tissue. It can manifest similarly to cellulitis with warmth, erythema, and edema, but it also causes a lot more pain. So you would see pain out of proportion to the exam findings. So with her pain at only a 4 out of 10, that seemed pretty consistent with the exam findings. Um, Necrotizing fasciitis could also be associated with a rapidly progressing erythema and signs of systemic toxicity, such as a fever or any signs of sepsis. So, since her erythema presented gradually over the past 4 days and the pain was not very severe, I didn't believe that she was showing signs of necrotizing fasciitis, and she was also not showing any symptoms of systemic toxicity. So, that wouldn't be the most likely diagnosis. My next differential is gas gangrene. So this typically occurs at a site of recent surgery or trauma, and it's usually accompanied by a fever and severe pain. Tissue crepitus is the hallmark sign of gas gangrene, which I didn't palpate on her, any crepitus. So since she didn't have any recent trauma, recent surgery, and she did not have crepitus, this wasn't my most likely diagnosis. And then my third differential that I had to keep in mind was erythema migrans. So, erythema migrans is a circular, non tender, slowly progressing round or oval rash with central clearing that occurs following a tick bite. So, she denied that she had any bug bite that she knows of, and she hasn't been outdoors lately. So, it's not likely that she was bit by a tick. And since her erythema was tender and it did not have central clearing, it really didn't look like this bullseye rash. So, this wouldn't be the most likely diagnosis either. So, the plan for this patient, we diagnosed her with cellulitis based on her clinical manifestations alone. Um, and she didn't meet any criteria for additional laboratory testing, so we didn't do that. But we did start her on cefadroxil, otherwise known as Keflex, 500 milligrams PO Q12 for 5 days. We told her that if her symptoms do not begin to improve after the first 48 hours of antibiotic use, to call the office. We told her to avoid NSAID use for pain control as it could mask the signs of worsening inflammation, which you would need to watch out for in case she was developing a necrotizing fasciitis. Um, we educated her that if the erythema was rapidly progressing, if the pain was increasing, if she developed a fever, if she developed shortness of breath, that she should go to the hospital. We also told her that she should elevate her leg as much as possible. So elevate the foot above the knee level and then elevate the knee level above the hip level in order to mobilize the edema in that leg. Um, and for an area of cellulitis, it's common for it to begin weeping or blistering or cracking, which would be normal, we told her. But if that does happen, we want her to call the office so we can set up a wound care consult to manage those openings in the skin so that she doesn't get a worsening infection. So, the classic presentation for cellulitis includes a patient presenting with an area of skin erythema, edema, and warmth. A fever and systemic signs of infection can be present. The lower extremities are the most common site of cellulitis. Um, Cellulitis is almost always unilateral. So if you have these symptoms bilaterally in two extremities, like both of your legs, you should really consider a different diagnosis. Um, Localized symptoms of cellulitis commonly develop gradually over a few days. Patients can have enlarged lymph nodes regional to the site of infection, and cellulitis may or may not be associated with a drainable abscess or a visible break in the skin. So you might see a wound where maybe the bacteria entered through, or you may not, and there also could be an abscess that you could drain, or maybe not. So guidelines for the diagnosis of cellulitis is to basically diagnose it based on clinical manifestations in most cases, so just by the symptoms. Laboratory tests are not recommended for patients without complications. If there is a drainable abscess, the abscess should be incised and drained. But a culture of the debrided material or blood cultures are only warranted in certain circumstances, which could include if there's a severe local infection, if there's signs of systemic infection, like signs of sepsis, if there's a history of recurrent abscesses, if you already tried antibiotic therapy and that has not been effective, if the patient has comorbidities such as malignancy or is immunocompromised, or if there has been an animal bite or an exposure to a body of water like a lake or a hot tub or something like that. If a patient has recurrent cellulitis, it may be indicated to obtain serologic testing for a beta hemolytic streptococci, but that's not what's happening in this case. This patient did have a recent admission for cellulitis of the right toe, but just twice wouldn't really be considered recurrent, so we didn't need to do that. So, guidelines for treatments of cellulitis of the extremities are as follows. Patients with red flag conditions of cellulitis need to be admitted to the hospital for parenteral antibiotics. So, we'll cover the red flag conditions shortly. But patients without red flag conditions can be started on enteral antibiotics. So the two most likely pathogens of cellulitis are beta hemolytic streptococci and methicillin sensitive as aureus. So the antibiotic therapy should always cover those two pathogens. And then certain patients who meet the criteria for MRSA coverage would include the following. That would be patients with symptoms of systemic toxicity, patients with cellulitis that has purulent wound drainage, a known MRSA colonization or infection, a patient who is an IV drug user, or a patient who is high risk and is neutropenic. So 5 to 6 days of antibiotic therapy is recommended, and patients should see improvement within the first 24 to 48 hours of treatment, according to the guidelines. So, how you pick the treatment for the cellulitis is you would use an algorithm such as this from Up to Date. So you just go through and answer the questions, and based on the patient's allergies and certain conditions they might have, you follow this algorithm and you can pick your antibiotic to use. So, some non pharmacologic treatments that are also recommended are elevation of the limb to mobilize the edema. And you want to manage the points of entry of the bacteria. So, if there are breaks in the skin, you want to manage those wounds. And ulcers between the toes, you should definitely look for those if the cellulitis is on the legs, because those could be a common site for bacteria to enter. Treatments to avoid with cellulitis are the use of NSAIDs and corticosteroids because they can actually mask the symptoms of evolving necrotizing tissue infection that you want to be looking out for. So you want to be looking out for symptoms of increased inflammation because that could tell you that there's a necrotizing tissue infection going on. So you don't want to mask those symptoms. So no NSAIDs, no corticosteroids. So you can tell the patient to use Tylenol if they need pain relief. And then topical antibiotics also should not be used because they haven't shown to be effective since the infection in cellulitis is deeper than just the surface. So the cellulitis red flags you need to look out for. Um, the following conditions that may accompany cellulitis require immediate hospitalization. So that would be sepsis and septic shock. So you would know or be concerned about that if the patient has a high fever, if they're lethargic, if they're hypotensive, if they have a sustained tachycardia. If they have a rapidly progressing infection, so very rapidly progressing edema, very rapidly progressing pain or redness. If they have pain out of proportion of the exam findings, so if they're complaining of pain that's way worse than the symptom, like the way the wound looks, that's a red flag. Crepitus at the site is a red flag. Joint involvement is a red flag, and compartment syndrome, the symptoms for that are a red flag. So, these manifestations are all associated with a high morbidity and mortality, and they need immediate intervention at a hospital and could need surgical intervention. So, for this patient in the case study, we did use the guidelines when formulating her treatment. So, I used that antibiotic algorithm that I showed to put her on the cephalexin, and we did it for the recommended 5 days. We also recommended that she elevate her leg, which is in the guidelines, to mobilize the edema. And we told her not to use any NSAIDs for pain, which is part of the guidelines. And we also educated her on the red flag situations and when to call the office or when to just go right to the hospital. So now for the certification questions. Number one, what are the hallmark manifestations of cellulitis? A, presence of vesicular rash accompanied by fever and chills. B, circular erythema with central clearing. C, area of erythema with crepitus noted on palpation. Or D, area of erythema edema that is warm to touch. Number two, which patient presenting with symptoms of cellulitis should be referred to the ED? A 78-year-old female with cellulitis whose vitals are temperature of 101, heart rate of 112, and BP of 85/50. A 65-year-old male with diabetes who reports erythema and edema began gradually 3 days ago to the right forearm. C, an 85-year-old male who reports 2 out of 10 pain to his right shin that started yesterday. Or D, a 60-year-old female with hypertension who presents with erythema, edema, and warmth to her left shin at a temp of 99.9. Number three, the nurse practitioner is assessing a client diagnosed with cellulitis of the upper leg, upper left arm in the hospital setting. Which manifestation can the nurse anticipate finding with this client? Select all that apply. So A, swollen lymph glands, B, deep, firm, painful nodule, C, fever and chills, and D, erythema. Number four, which medication should be avoided in the treatment of cellulitis? Keflex, ibuprofen, Tylenol, or linezolid? And number five, how many days of enteral antibiotic therapy is recommended for an outpatient with uncomplicated cellulitis of the lower extremity? 10 days, 5 days, 7 days, or 14 days? And there are my references. Thank you very much for listening to my presentation.